It's my pleasure again to invite Dr. Watson to speak on corneal cross-linking.
Thank you again. Corneal cross-linking. So as we've heard already, it aims to strengthen the cornea by putting little bridges or cross-links back through the stromal layer. But how I like to explain this to patients is the cornea is a bit like a sandwich with layer upon layer, and in keratoconus that sandwich becomes a bit sloppy and the layers all start to slip. And cross-linking is like putting little toothpicks in your sandwich to keep it all together. The mechanism of action is thought to be possibly biological, mechanical, chemical, but there's a number of mechanisms that are causing this chemical strengthening of the cornea. Now, when might be corneal cross-linking considered? Well, it's typically done for corneal ectasias such as keratoconus, post-LASIK. It's also been suggested for pellucid marginal degeneration, and there's been some reports of its use in Terriens. It's been used in microbial keratitis, and it's also been suggested for corneal ulceration and bullous keratopathy. Now, when to perform corneal cross-linking? Well, we've already heard this morning about progression and keratoconus and how it can be difficult to judge when keratoconus is getting worse. This table here shows some of the criteria that have been used in published studies of keratoconus that have determined progression. But the steeper keratoconus is, the more variability you'll get in your pentacam scans. When the cornea is very steep, even repeating the scan on the same day, you can see a 2 to 3 diopter variation, or even up to 3 to 4 in the readings for keratometry. And so it's good to have more than one measurement or one indice that you're using to tell whether the patient's progressing. But in some cases, as we've heard, you may want to go to cross-linking if there's a high risk of progression, and that's particularly if the patient's an eye rubber, if they're very young, and in these cases you discuss the risks versus the benefits. Now, you can have patients that have had cross-linking who may continue to progress, and in these cases repeat cross-linking can be performed, particularly if their first procedure was an epi-on procedure, because it may not have been as effective. Contraindications. Well, traditionally it's been said pachymetry less than 400 microns is a contraindication. There's new methods that are being used to try to swell the corneal stroma, or use things such as bandage contact lenses during the procedure to allow treatments at these thinner levels, but there is a risk to the endothelium. Herpes is a contraindication because you can get reactivation, and if there's a history of excessive scarring. Now, traditionally, cross-linking has been done with what's known as the conventional or Dresden protocol, and this involved using UV light at around 3 milliwatts per centimetre squared and takes 30 minutes of treatment. But now accelerated cross-linking has been introduced, and this allows the UV time to be decreased, and therefore the treatment time. It gives a higher energy, but the cumulative dose is the same. Now, there are many different protocol variations that have been introduced for corneal cross-linking, and these have attempted to treat thinner corneas, but also to reduce the adverse events, such as infection, by allowing epi-on treatment, and trying to make the treatment more effective, also trying to regionalise the treatment. So I established the SaveSite Keratoconus Registry in 2015 to collect data on keratoconus and corneal cross-linking to try to determine which procedures might be best. And there's now 92 users across the globe with around 4,000 patients. And what we found, looking at our 5-year outcomes, and this included patients that had half had accelerated and half had conventional, that there was an improvement in vision at 1 year, and this improvement actually increased. So there was further improvement by 5 years. The keratometry was stabilised, but there was also some continuing flattening over time, and most of the adverse events occurred within the first year. So there's very, very few late adverse events. This is showing what happened over time, and you can see in the graph here that there's this gradual improvement in vision. Interestingly, there's also some initial corneal thinning, which then stabilises. A recent study that we've just published has shown that it also improves the quality of life of patients. So this can be very reassuring when you're counselling patients about the potential, about the cross-linking procedure, because many of them have read online about how painful and horrible it is, that afterwards they'll actually have an improvement in their quality of life, in both their symptoms, what activities they might be able to do, and their emotional status. And this because vision can actually improve a little bit. Now, when we looked at conventional versus accelerated cross-linking, we found that both treatments were about as effective in stabilising vision, in stabilising keratoconus, and for both, the adverse events were low and similar. So, in general, accelerated cross-linking may be considered because it creates greater patient comfort and convenience for the surgeon. One of the treatments we've looked at recently is oxygen, and it's being used in corneal cross-linking to allow shorter treatment times, but ensure that the treatment is equally as effective, because during the chemical process, it's thought that the lack of oxygen can reduce the reaction. And this is a systematic review we recently published looking at the use of oxygen in corneal cross-linking, and we found that it actually improved vision and produced corneal flattening without any serious adverse events. So it can also be considered for use in cross-linking with keratoconus. Reassuringly, if your patient has had cross-linking, you can say that you can have a corneal graft. There's no trouble performing a DALC after corneal cross-linking. There's no increased complications, and visual results are still good. We've produced a brochure that explains to patients about their corneal cross-linking procedure that can be downloaded for free. And this is very helpful because it often can be a painful procedure, and it does prepare them for that. Now, when we looked at our rate of adverse events, the most frequent one was corneal haze, and this is as to be expected. But most haze generally resolves by 3 months. Oh, sorry, this just jumped. Jump forward. Other adverse events include scarring, sterile infiltrates, edema, keratitis, persistent defects, recurrent erosion, and steroid response. But as you can see, most of those occurred in the first year. Haze decreases, as I said, in the first year, and generally extends to about 60% depth. So it's a little bit deeper than PRK haze. Now, we reported a case series of corneal infection after corneal cross-linking, and this was 11 eyes from 10 patients, and the median time to infection was about 4 days, though some cases did present late. And so it's important to remind the patient to use their topical antibiotics in this time to try to prevent infection. And the patients that had infection had reduced vision afterwards. We had a culture positivity rate of 92%, which is quite high, and we isolated 13 isolates, which were mostly coagula-negative Staph and Staph aureus. And patients that had an infection had very delayed healing, up to 30 days. So after cross-linking, if you see a keratitis, it might be gram-positive. There's probably delayed epithelialization, and the outcomes may not be good due to corneal scarring. At our institute, we had around a 2% incident. So corneal cross-linking is effective in stabilising vision and keratometry. Vision can also improve in some cases, and there's many techniques, which is why I think we need to continue to monitor the outcomes using things like registries, so we can be sure that the technique that we're performing is going to deliver the best results to our patients. Discuss the risks and benefits with your patients. If you're interested in joining the registry project, you can. The details are shown here. Thank you very much.